And if people are squirming in their seats, hearing some of these things, we can even talk about it in the question portion. So,
no darts.
So number 4 for the panel, what historical and present day issues contribute to nearly 1/3 of Americans, or 114 million people, having no dental coverage? I'm asking you big questions, and if you solve them all tonight, you'll get a prize.
I'm going to do the easy part of this. Health insurance or dental insurance, just like health insurance, is driven by the employers. And they determine what they're going to offer their employees and to what level, whether they're going to cover it or whether the employees have to select it and pay for it themselves. And so that's the main driver for the dental insurance community. We are seeing a growth. One of the other things that I do, I'm on the board for Delta Dental. Dr. Thies, he's our new dental director at Dental. So if you have any questions about him, he's your man. About that. But we're seeing an increase in individual policies where people are just going in the market and are buying dental insurance just on their own, which we never saw that 10 years ago. So that will be hopefully making a difference here. But up till now, it's been a benefit and has been changing, and hopefully, as this discussion goes on, the importance of that will become more to the forefront. Because the statistics are very clear. If you don't have dental insurance, you probably aren't going to go.
And our public programs reflect this division too. I mean, Medicare, which covers over 55 million older and disabled Americans, has never included routine dental benefits as part of its program. So, tens of millions of seniors are dentally uninsured. And of course, as we pointed out, adults covered by Medicaid are not guaranteed a dental benefit. Children are entitled to dental care under Medicaid, but it's up to the states how they manage their adult population. So some states don't offer any dental benefits to adults at all, and others have meager benefits, and others have full benefits. But it depends on where you live.
And I think one of the issues, if you're looking at historically, dental insurance started, I think, in California in 1954. In the 60s is when it started to come more nationally. Well, the benefits back then were $500 to $1,000 a year. What are the benefits now? About the same. $1,500 maximum. I can guarantee you, unfortunately, I'm not just picking adult dental because they were one of the proponents that started. Your premiums are a lot higher than they were back in the 60s, and you're still not getting a higher rate. And that's one of the problems. I mean, when you're looking at, you walk in, before I left practice, you came in my office for a crown, it was $1,000. Well, if you got $1,000 worth of benefit, guess what? You're done. And if you don't have insurance, if you're looking at somebody on the poverty level, for example, 100% of the poverty level is $12,500. And if you're trying to live on that and support a family, are you going to walk into a dental office and say, yeah, I'll take that crown? No, you're going to opt for the extraction because that's what you might be able to afford. And that's one of the big problems.
Just to kind of reiterate something that both Mary and Dr. Kinzel sort of built on is this issue of adult Medicaid benefits and the importance of having some sort of insurance. While we are last in utilization for kids and we're low for Medicaid reimbursement, one of the things we can hang our hat on is Wisconsin does still have an adult benefit for dental. There are many states that, as Mary said, that have removed that, and I think, as Dr. Kinzel said, you have a parent that is not insured by Medicaid for dental benefits, they again will be less likely to have their kid go in for dental care. So it's a good thing that we hope will stay in place, but unfortunately when states start looking to cut things, that's been a critical point where many states have removed that adult benefit from their formulary, and then they no longer have dental coverage.
Thank you. So we've already talked a bit about the Amante driver. Since that kind of seminal 2000 Surgeon General's report came out and said this is a huge issue in the United States, I think people would be interested to learn what progress has been made for this population in dental.
In the most recent federal data we have, slightly more than half of children covered by Medicaid got a dental visit in the most recent years that we have federal data for, which is a big advance over the fraction that got care before, in 2000. The outlook for adults is still not good. And this growing senior population, is feeding the uninsured, baby boomers are aging into retirement and aging into a population that's less likely to have dental benefits and access to care, for a lot of different reasons. Like, the thing that came back to me over and over as I was working on the book is the complexity of oral health and the factors that contribute to oral health and disease. And so our oral health is a reflection of many conditions in our lives. And yeah, it's of course it's important to go home and brush your teeth at night, but that doesn't solve all the issues.
I think too, in Wisconsin, we've made some significant strides in improving the oral health of children. The Wisconsin Seal a Smile program, which we manage through funding that comes both from the state budget, so GPR dollars, and then also matching dollars from Delta Dental of Wisconsin. That program has grown significantly. That program started almost 20 years ago with a pot of money of about $60,000, and it's now up to close to $700,000, potentially more if the governor's budget moves through. But that program has made a significant impact on providing school-based oral health services, which OHP does. Our program provides funding to about 40 different entities across the state. They serve about 850 schools and reach about 70,000 kids every year. And throughout the duration of our program, what the state has done is they have continually evaluated the oral health of third graders, which is a really critical age because oftentimes we're putting sealants on first or second graders. And in the past 15 years, the last 3 oral health surveys that have come out, and one that is pending coming out, I haven't seen the data yet, but I know it's getting ready to be released. We've seen strides made. We've gone from 31% of kids having untreated decay down to 17%, and we've gone from 47% of kids having dental sealants to 61% of kids having dental sealants. And probably most significantly, we've impacted kids that are in schools with really high free and reduced lunch rates. So back in the 2008 survey, only 35% of those kids had sealants. And in the last survey, over 60% of them had sealants. In fact, they were more likely to have sealants if they were in a high-risk school than a low-risk school, which is really what our program is geared to do, is to take care of kids that aren't accessing services. So we're making strides. It's not all doom and gloom in Wisconsin. There are some bright spots.
Matt is right. We've actually seen some notable strides, especially in the children's, but unfortunately, I'd have to say from an adult perspective, we've got a further way to go. I'm going to talk about a different state for a second. A few weeks ago, I participated in a webinar with the Texas Oral Health Institute that studied emergency and urgent care data from 2007 to 2016. And their data came up with in 2016, they had 10 deaths that were related to non-traumatic dental disease. Now, I've granted Texas population is 28 million and we're 5.8. But to me, 10 deaths is 10 too many. Especially when you're looking at an illness that's preventable. It's not cancer, we can prevent this. We can do something to stop this, and it's still going on. I don't have any statistics yet for Wisconsin, but my understanding is we had no deaths in the last 2 years, and thank God for that, but we've got to step up. We've got to do something.
I don't have the expertise to really answer that. I don't have the data or the knowledge. My only comments are that when Diamante passed away, he became the poster for this discussion, but the amount of press and the amount of hearings, the results have not followed through. For a while it looked like the tragedy was going to change the whole complexion of the federal dental health Medicaid arena, and it just never translated into real action. So there's still a lot of cracks for people to fall through.
So do you believe we have a shortage of dentists? And how would you solve access to care issues in rural communities? So we talked about teledentistry. Maybe someone could explain that a little bit.
Well, teledentistry is involved where you have an outside practitioner, and medicine's been using it again. I hate to keep using that model because I know we're comparing apples to oranges, we're talking sometimes dental to medical. But you've got a nurse practitioner, a physician, or a physician's assistant that can actually transmit an image or an x-ray, etc. And dentistry can do the same thing. They can take a digital x-ray and transmit it to somebody within seconds. They can take an intraoral photograph, and a practitioner can take a look at that and say, yeah, that's something that I think is beyond your scope of practice. Now, is that 100%, is that a 100% solution? No. But it does offer some better options for treatment and treatment expansion that we could use from that standpoint.
Whether there's a shortage of dentists or a maldistribution dentist doesn't matter. There's still people that don't have places to go to the dentist. This is not a simple problem. It goes back to the rural economy that is viable in that area. I don't believe that you'll know the true accessibility of care in the rural areas until you have funding for the program to fund it adequately so that dentists can see the patients. I don't think we know what the capacity is. And I think that there's a lot of capacity out there that is not being tapped into, and it looks more of a shortage than it really is.
And that's one of the other problems we're looking at. We're not sure if it's a dental shortage or if it's a geographic shortage. And that's one of the things we have to look at. And it's just not rural areas. When I look at the dental shortage map, there's actually areas in Milwaukee and Racine, two of the largest populated areas in the state. There's still dental shortage areas. One of the things we need to be looking at, and I think it was good to see the governor looking at least from a multifaceted or multi-pronged approach, is loan forgiveness. And that's both for dentists and hygienists to get them into areas that are unsafe.
One bright spot is since the passage of the Affordable Care Act, community health centers across the country have gotten expanded, and this is more happening in states with a Medicaid expansion than not. But they've found they have larger patient caseloads now and more funding, so many of them have added dental and mental health professionals to their staff. So people now have this community health center where they already go, and they can get, they're sort of expanding the definition of primary care to include badly needed dental and mental health services in a lot of underserved communities.
So I'll just speak specifically to some of the work that we've done on the prevention side, especially in the rural parts of the state. Many of the federally qualified health centers in rural parts of Wisconsin have become very, very high-level providers within our sealant program. And one of the nice things about partnering with a federally qualified health center is they have a direct referral source to bring that child in when 40% of the kids we see need follow-up care. So they can actually provide that care. So I think, to answer your question about is there a shortage of dentists, I don't really know. There's reports that say there are, and then there's reports that say there aren't. My personal viewpoint is I think there's probably more of a maldistribution of dentists, and I can tell you from example, when we work with schools in inner city Milwaukee and one of the zip codes that has the highest level of Medicaid enrolled kids, there's if one dentist maybe that's there, and they luckily take Medicaid, but you can have 50 dentists there, and if none of them take Medicaid, they're in the wrong place at the wrong time. Whereas you could go to another part of the community, stand on a corner and do a turn 360 degrees and count 10 dental offices. Again, if they're not taking the insurance you have, it's not really doing the patient a whole lot of good. So again, it's really a multifaceted, complex issue.
And because we don't want to leave our audience worried about multifaceted, complex issues when they go home, and we're going to give them answers. If each of you would comment on what you think a few of the most promising solutions might be to improve our nation's oral health. I mean, you're the experts, so let's hear what you think. It's going to be recorded, so you can't take it.
Oh, goody.
Well, I was going to answer till you said it was going to be recorded. I kind of thought twice, but I'll jump in. I think about this quite a bit, and I kind of lump this issue into three buckets. I think that we have to do a significant amount of work around the financing of dental care. So I think we have to look at how Medicaid, which is, as Dr. Dunkel said, the largest payer, is paying the providers that are providing this care, and who they're paying. In our state in Wisconsin, Medicaid will reimburse dental hygienists directly for the care they provide, but that only occurs in 19 states, so not in all states can that occur. So I think that's one bucket. Another bucket is around regulatory issues. So the way that dental hygienists can practice is different in every state, and the ability for dentists and dental hygienists to get a license to practice in one state to the next is very difficult. Just recently, the governor in Arizona signed a piece of legislation that allows healthcare providers from any state that have a license to provide care, this is not just dentistry, have a license to provide care that's in good standing, they're able to come to Arizona and get a license. That's not the case in most states. We have providers that live in our state right now that have either been trained in other countries but have completed residency programs in the United States that are CODA accredited, which is who accredits dental and dental hygiene schools. And because of our regulatory issues in Wisconsin, they cannot get a license to practice care. So that's the second bucket, is we have to look at regulation and we have to look at license portability. And what's kind of exciting is the American Dental Association, the American Dental Education Association, and the American Student Dental Association, along with the American Dental Hygienists Association, who, as a slight disclaimer, I currently serve as the president-elect for the American Dental Hygienists Association, have all gotten together to start looking at license portability and looking at interstate licensure compacts. So this exists already in nursing and physical therapy. So we just have to find a way to make our licenses more portable so that when we move from one state to the next, we can actually practice. And then I think the last bucket that I'll just mention is workforce, and regulatory are kind of tied in together. I think we have to make sure that all providers, whether it be dental assistants that are licensed, whether it be registered dental hygienists, states that allow dental therapy, which more should allow dental therapy, and dentists, that everybody's practicing to the top of their license. And that doesn't occur in every state either. And a very simplistic example I can give you is in 45 states, dental hygienists can administer local anesthetic, and in 5 they cannot. So the way you practice in one state is very different from the next state and the next state next to that. And that's not utilizing the skill set of a provider at the top of their license and maximizing everybody that's part of that dental team. That requires the dentist to then be pulled away from a patient and doing a procedure that's much more complex, that they may be the only ones trained to do, to come and have to do something that in 45 other states as a hygienist I can do. So we have to really maximize the workforce and use it more efficiently.
Well, unfortunately, as state dental director, I have to kind of be careful with what I say, because I work for the state as well. One of the things I think that's going to help is the fact that Mary had mentioned before, and so did Michael, is that the Surgeon General has come out publicly, and they're actually doing a study report that will come out at the end of the year addressing the needs and effects of oral health and oral disease. I think that's going to be a big plus to help move the needle forward. And from a budget standpoint, there's only so much I can comment on. I mean, the one thing I can say is it's nice to see that they've come up with an idea there's no one solution. There's no one idea that's a panacea that's going to solve the problem. It's a complex, extremely large problem, and it's going to take those kind of solutions to solve it. One thing alone is not going to do it. And I'll be the first who was stepping back as a dental provider before. Raising the Medicaid reimbursement rate is going to help a lot. I think loan forgiveness also can be a big part, especially when we're looking at geographic shortage areas.
Dental disease is a multifaceted disease, and it's not as simple as we used to think that it used to be. And the solution has to be a multifaceted solution. There's no way about it. And the reality is that government, if they're going to be in charge of the medical assistance program, has to realize that they have to put money into the program. Because it doesn't make a difference whether a hygienist does a service or a therapist does a service or the dentist does, they still got to pay for it. And it's not going to decrease their cost. It's going to, the more people that are seeing it, their costs are going to increase. And if they don't have the commitment to spend more money, they're not going to get anywhere.
You know, as I've been reporting on this subject, it struck me that I think one of the reasons Dr. Satcher called the oral health epidemic a silent epidemic was that the people who are really in the place to make changes to the system don't understand it's there. I mean, they've never had a problem with getting access to care. They've taken it for granted in some cases and never had to look for it. So for them, there's no problem, you know? I think too that the answer is making a healthcare system that reflects our bodies and our lives and our health, you know, making it an integrated system where oral health care is integrated into overall health care, and the system prioritizes and rewards referrals and whole patient care as opposed to the fragmented kind of care we get now.
Thank you all so much. We're at just about 8 o'clock, so I'm going to apologize, but extend it, if that's okay, 5 minutes at least for questions. And, you know, no bad questions. If you're wondering, go ahead and ask it. I'm still new at this and learning a lot, so please raise your hand if you have a question. I'll bring in the mic. Dr. Van Miller, how did I know?
Yes, Mary, I read your book and kind of gleaned from the first part of it about the issue about cosmetic dentistry in the dental field nowadays, and I think Tim said something about the advertisements always indicate straight white teeth. I was on the board at the dental school for a long time, and most of our dental students are graduating with about $250,000 worth of debt. And it's pretty hard to understand the complexity of what goes through their mind when they get into a practice environment and they look at this issue of accepting Medicaid, or can I do a crown, can I do some veneers that are very highly productive. And I think a lot of the stuff that's going on out there is a problem with this debt situation and people not wanting to go into rural areas and help people who are underserved. So I think what we have to do in the dental field is maybe make people realize that this shortage really does exist, because I don't believe our dental students at Marquette understand this problem either. And I've talked to the dean on a number of occasions about getting out into the community, although we have community health clinics in Milwaukee area and stuff like that, where they get to see some of this stuff. But it's a big financial problem for these students when they get out of school. And one of the things I think Russ, you said it, about, you know, some kind of a debt reduction or reimbursement plan for these people, and maybe you can entice them to get into some of these rural practice situations. So that's not a question, I'm just making a comment.
I want to, Dr. Van Miller is a retired pediatric dentist. He was not only someone that I looked up to, but I considered a mentor. And when he speaks, people should listen, because he's above the rest of us. But I will, as always, to say thank you, and plus he was beating at golf too. That's another story. And also, since I mentioned Dr. I want to mention Dr. Eggert, Heidi. It was her dad who was on the screen before, and when you realize that these are people that are on the board for OHP, it's no wonder that you're successful and that you do the job that you do. We need to tell the dental students that there's a lot of people, they just want their teeth fixed. And there's a good living to be made fixing people who just need their teeth fixed. And there's a good living to be had in smaller rural areas. We don't do a very good job of that. Part of it is the economics and the student debt. And if I was graduating with $250,000 or $300,000 or $400,000 of debt, I'm wondering where my paycheck's coming and I need it next week. We don't have the luxury to sit around for a while and figure our life out. And so it makes it harder to get into the areas where you don't have that certainty of a practice. It's changing the complexion of our practice at the same time.
And without some of that education, just at the conference, we heard 68 out of nearly 5,000 graduating dentists went into public health. Only 68 of 5,000 went in to work on the issues that we're talking about. So, other questions?
Tim, you haven't addressed one of the newest things that we have in dentistry that the Food and Drug Administration has approved a part of it, SDF. And which is, I know Mary was too early or too late to get in your book. I'm sure you would have addressed it. But would you just comment briefly on the role of silver diamine fluoride?
Yeah, silver diamine fluoride, SDF. It is a compound, obviously has fluoride and silver in it, that the way it works is if you paint it on a cavity, it'll soak into the cavity, basically kill the bacteria, and then we call it arrest the decay process or stop the process. We've been applying SDF in our office for like 2 or 3 years now, and it's a daily application for us. We are able to use that to delay treatment for patients to the point sometimes where they don't need restorations. We are finding that it's not 100% successful, and that we have some failures with it, and in certain instances where it doesn't work very well. But it's certainly becoming part of our armamentarium in pediatric dentistry to change what we do.
Yeah, Tim is right. It is something that's out there that's helped, that has the potential to help a lot. The key is to remember that it can't be placed on a symptomatic tooth. It has to be an asymptomatic tooth. And fortunately, after a little bit of pushing, I was able to get, along with other people, silver diamine fluoride is covered by Medicaid now. And we were able to limit restrictions. Initially, there was a lot of restrictions that they wanted to place on it. We were able to get those all removed. So that's great from that standpoint, and it really helps the state.
The other thing that I'll add is that what we're finding is that for the kids that have a very hard time having a filling, it's really hard to put the SDF on too. So it makes it, that's part of the success failure that we have.
Yeah, Tim's right there, but the other thing is to look at it. I've been treating special needs patients for probably even 40 years because I did it in dental school as well. And for some special needs patients, using the SDF may be the only treatment that we can perform for them and prevent them from having to go and me to do a more invasive procedure in the operating room or a colleague to do that. So it also helps from that standpoint as well.
Question right here.
So I'm going to go back to, I think, what was the first question around access. And a comment was made that we don't know what it means to solve the problem, that we haven't sort of either come to consensus or there's not a process or structure in place to come to those decisions. So I'm just curious, and I'm not coming at this from a critical standpoint. I'm curious just in my own work and as we think about multi-layered, complex social problems. So one, is there a process or a structure in place where you're having that conversation? And two, who are the decision makers? And some of the comments you made at the end, Mary, around how are we involving people who are dealing with the failures of the system in that process, if at all?
Well, there is the new edition of the Oral Health in America is being produced by the National Institutes of Health. It was, going to be out in a year or so, or maybe the end of this year. It's in the process of being written or developed right now. And there's federal data on oral health outcomes for every age group. National Health Examination Study Survey includes National Health and Nutrition Examination Survey, which is this ongoing, huge study, with mobile clinics and physical examinations of tens of thousands of Americans, balanced for populations and different ethnic groups, and all this is, accruing information on our oral health as a nation. And it's important work, that needs to be used. Something that hit me when Dr. Miller was talking about so much of our dental care is provided through the private practice fee-for-service system. And of course, its interests and its worldview are so different from public health goals, which are about providing cost-effective care across entire populations. It's a different side of the coin. And public health has been overlooked in all aspects of our healthcare system, and dental care mirrors that in a lot of ways. But a lot of the challenges we're talking about now are public health challenges that need to be addressed through public health work. And data and federal and research and understanding better what drives oral health and disease and the factors that affect it and how we can address this problem. It's good research and science.
When you talk about financing oral health and the decision makers that need to be at the table to make those decisions, I think one of the things that needs to be looked at, and there's some states that are doing this, Oregon is doing this and has been pretty successful, is they've moved to more of a value-based payment model. So right now in dentistry, we're paid based on providing service. So we get paid to do a filling, we get paid to do a cleaning, we get paid to do a crown. We're not incentivized in any way by keeping a patient healthy. In fact, it's potentially could be made the argument is the opposite. And so until we shift that payment model, again, it gets at those three buckets, that financing piece, until you change the way, not just how much we're paying for services, but how we're incentivizing providers to keep populations healthy, it's going to be a driving issue.
My friend Chris Quorum, who's the executive director of the Wisconsin Collaborative for Quality Healthcare, will be in this discussion right now. The problem you have in the dental world is that when you tell us you're going to judge our quality, we think they're going to look at our fillings and see what our margins are and what the margins are for the crown, as opposed to it's really the systems you have in place for your patients and that you're following accepted protocol. We're working very hard to become evidence-based in our dental practice and what we do and what we recommend. And so that's a whole other realm as far as how that would work or how you can incentivize that. As far as who's making the decision or going to decide what success is, I don't know. There's a lot of different coalitions and conferences and committees that try and discuss this, and everybody comes at it from a little bit different angle. I think that's hard to know that. If you want to go for the federal government, their directive in the Medicaid program is that the state needs to run a program that the people on Medicaid have the same access to care as that the rest of the population does. And that's their rule of thumb. And we obviously fall way behind that, but it's if you want a government statement, that would be it.
So I think at this point, I think we should move along. I am hopeful you all will stay up here for a little bit in case someone else has another question that they can ask. Did want to highlight, with the support of Rosie and Rachel and our coalition, we have an oral health coalition group and members in the room. We are putting on another event in the fall with Dr. Brian Novi. So he's with DentaQuest. Really interesting person. This is more of a continuing education CME event. So any dentists who are interested in the room, we will be hosting this. And a big thing we're going to talk about is medical dental integration and how we can do it. So again, thank you to all of our sponsors, especially DHPI, St Norbert. Great job. If any of you are still in the room, thank you for your support. I would especially like to thank our esteemed panel and Mary Otto for coming out. So please join me in thanking them. We do have a book to give away, so Mary, if you would do the honors and that. And Dr. Margaret Miller. Dr. Miller, where are you? Well, thank you all again so much. Mary Otto will be just outside the door signing books. She does an awesome inscription, I know because I got one. If you would like that on your book, I think she has a few for sale. Thank you all again for being here. I think some of the most important work in our country happens after 5 p.m. with people learning and volunteering. So have a great night. Thank you.